The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan again, and I'd like to welcome you to our Safe and Calm webinar for Wednesday, August 5th. Before we get started, I have a couple announcements to make that I don't have slides for, so I don't want to forget. On Friday, last week, we had a question come in about a recurrent positive. In other words, there was a staff member who apparently was COVID positive, but was declared recovered, and later had negative tests followed by a positive test. And they wanted to know whether or not they should report that person as a new laboratory confirmed case. So we reached out to the department, who had to reach out to the CDC to decide whether or not that was reportable. And the rule is that they have to be recovered for 3 months or more. So after their onset. So if they have been stable for 3 months and considered recovered during that time after onset, then that would be reported as a new laboratory confirmed case. But there are also concerns, depending on the timing of those positive tests, as to whether or not they should consult an infectious disease expert. The CDC guidance does recommend that. The other outstanding question that we have into the state is a little bit more difficult, and this was raised a couple weeks ago, whether or not students and interns are allowed in the building right now as part of their clinical experience. We don't have a good answer for that yet. We reached out to the department of MDHHS. They referred me to Laura. Laura's referred me back to the department. So it seems to be a question about who's governing that piece, but we will continue to try and get an answer. So then for today, we're going to use our standard agenda with a focus on Executive Order 148. As usual, we'll start with our advocacy update, and Dalton will be reviewing the status of the Attorney General press release that has been proposed. It still has not been issued as far as we know. And that press release is about the enforcement of executive orders and specifically targets 148. We will then follow with our normal situation update and a review of resources and guidelines. So with that, we will turn the presentation over to Dalton, our Director for Advocacy.
Good morning, everyone. Welcome to the Leading Age Safe and Calm call this morning. For today, we'll be going over a brief legislative and federal update, state legislature update, and then covering the Attorney General press release in brief. We have a little bit more information, but as Deanna said, it's still not finalized and they're still working through it. So moving forward, the legislative update for the state. There was supposed to be session this week, but as I'm sure some of you are aware, Senator Tim Barrett tested positive for COVID. That resulted in a lot of committees being canceled this week. In fact, I think almost all of them were canceled, and the session was canceled as well. An interesting thing to note is that this will not affect the FY 2021 budget timeline, as these committees are being moved back a week or two, because the budget has to be done by October 1st. It's kind of a drop dead date. So there's no way it can affect the timeline because they have to get done. A brief update on the budget. Right now, they're still hoping for some form of federal aid to help out the Michigan budget. You may have also heard that Senate Bill 956, that Lucido bill that would have created COVID care centers in each of the 8 HSAs throughout the state and not allow nursing homes to take care of COVID positive individuals, that was vetoed by the governor. I think this quote was pretty powerful as to how she was viewing that legislation. She said that the Senate bill is nothing more than a political game that would relocate vulnerable seniors without any requirement for consent, doctor's approval, or notification to patients and their families. So a lot of those issues were addressed by potential amendments through the legislative process, but they were not taken up on the bill package. So I believe that is why she came out so negatively against the bill. And also that Senate Bill 899, the legal immunity bill, is still waiting on a decision by the governor. She still has a little over a week to make that decision. And right now, the legislature is also working on some immunity bills for PPE manufacturers and providers of PPE, and also on some general employer immunity bills. Right now, the language in those is very, very general and will apply to everyone, but from what I've been hearing, I believe those are supposed to apply to school employees, but we'll see. Right now, it's very, very general, and it's still very early in the process for those bills. There's still not complete language in them. As for the federal update, we covered the HEALS Act last week, and the negotiations are still ongoing. The big gaps between congressional Republicans and Democrats are the employment benefits, the legal immunity protections, and federal aid for the states. They said they're getting closer, but in all reality, they sat in a room and listened to each other and didn't actually negotiate. They just kind of got the base for where everyone stands. There is some debate about whether long-term packages, such as these big HEALS Act bills, or shorter-term extensions to the current relief would be better, but all short-term extensions have been met with challenges and been shot down by the other party. As for where the White House stands on all this, they want to see some sort of relief package, but they believe Congress should be the ones to work that out. And the president has come out and said that if he hasn't seen anything within a timeline he deems acceptable, he will issue an executive order if a deal can't be reached. On to the Attorney General letter that we talked about on Friday, excuse me. The press release was supposed to be released on Monday, but they kind of pulled back on that a little bit, and they said they were going to issue it today. We'll see. We know nothing has been finalized in the Attorney General's letter, and it's still a little foggy as to how they're actually going to be involved. The focus, though, has expanded from the list that I read to you on Friday. The new list are specifically focused on things in Executive Order 2020-148, and these are evictions, communal dining, group activities, disinfection and sanitation regimes, PPE, and PPE, supplying your employees with PPE, informing employees of COVID-positive patients, and data reporting. This is going to be a coordinated effort between the AG's office, Laura, and MDHHS. Right now, as I said, it's kind of a little foggy as to what exactly that effort will be. Some believe it's just going to be the AG's office overseeing complaints. Others think it will be more of a concerted effort on them getting involved. We'll see. That's all I have for you today.
All right, thank you very much, Dalton. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the names on the screen above. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of names and also the logos and names to come further on in the webinar whenever you are considering on making a purchase of goods or services. Right now, looks like I have one question, and it is for Deanna regarding what she went over at the beginning of the webinar. Deanna, can you please clarify, do you mean stable for 3 months and then if positive it is a new case, or within the 3 months it is not a new case? Please repeat.
3 months from the onset of symptoms or a positive test. If there is another positive test, that is not reportable. Report only positive tests that occur for someone who was previously positive 3 months or beyond. So it is a new case starting at 3 months after onset of symptoms or positive testing.
Okay, thank you. It looks like we don't have any other questions, so we can go ahead and move forward at this time.
Okay, thank you, Blake and Dalton. We'll now go to today's situation update. So this next slide is a graphic that shows the density of active cases across the world as of August 3rd based on Johns Hopkins data. Johns Hopkins is actually the source of an awful lot of data for the United States. And these are just active cases. So you can see high levels of concentration in Japan, India, Europe, South America, and of course the US. This next map shows the incidence rate in the same way. So it's clear that the pandemic is growing in the most heavily populated areas across the world. And the United States, Europe, and South America are the largest areas affected at this point. This is the last heat map that I've included today. It shows the ratio between cases and deaths. And the U.S. Fares a bit better here when deaths are measured against the number of cases rather than population. The hotspots here are Mexico, Northwestern South America, Europe, and Japan. So there are really high death rates in all those areas. When we look at the U.S. statistics, and these are from earlier this week, you can see that active and recovered cases are pretty much split in half in terms of proportions. But what that actually means that half of all cases to date over this 5-month period are actively sick now. And if you look at the trends below at the bottom of the graphic, you can see that there's day-to-day growth in all areas of active, recovered, and deaths. This next map is from the CDC, and it identifies the simple raw number of cumulative cases per state. You can see that most states now register with more than 40,000 cases on a cumulative basis, and Michigan is, of course, in that group. This next map includes the number of total deaths over the entire pandemic period. Note that Michigan is a little bit more of an outlier here compared to other states, so that you can see that in terms of deaths, there are fewer states reporting high numbers. The Michigan statistics noted on the right side of the screen are from yesterday. And here is our routine 7-day rolling average of new cases for Michigan. And with our fingers crossed, it does look as if new cases might be leveling off. We need a few more days and weeks of data to determine that, but it does look like it's stopped climbing at least. And for our routine 7-day rolling average of daily deaths for Michigan, we saw a bit of a rise in the past week, and that might be related to the increases in caseload, but it also looks like it might be flattening a bit as well. And as of yesterday, the My Safe Start map posted on the website, including data as of 8/1, continues to show that most areas across the state are still at medium to high risk, except for the upper portion of the lower peninsula. So this has not changed since last week. As of Monday, Michigan reported nursing home data through August 1. With 98% of the Michigan nursing facilities reporting. Of all the COVID cumulative cases in Michigan, nursing home residents accounted for 9%. And when you include staff members with illness, that proportion rises to 13.4%. Resident deaths in nursing homes hover around 32% of all Michigan deaths. And that compares to about a 40% level in most other states, or an average across the states at least. We'll now move on to resources and guidelines. And as we said at the beginning, we're going to start with a review of Executive Order 2020-148, since that's the focus for the governor's executive order. We've only had one new executive order since last Friday in our update, and it was a simple amendment to 2021-60, and that was about worker safeguards. And it really wasn't, I think, highly impactful for members. So we're going to just review 148 today. This order is divided into 3 sections. This first section is called Enhanced Protections for Residents. Long-term care facilities must not evict or involuntarily discharge a resident for non-payment. We believe that it's this section that is at least partly driving the focus on enforcement right now, since other federal rules for evictions have lapsed. So I think that there's a real concern about this piece. We still don't have a good understanding of the kinds of scenarios that might be covered under the part that's highlighted here in the first bullet. You can't deny resident access to a facility. It's clear that they're trying to protect the resident's ability to reside and live in the facility, but I'm not sure of the scenarios, and I never have been. That language has been in this executive order from the very beginning. Facilities must not prohibit admission or readmission based on testing requirements. We believe that this was originally placed in the order to make sure that providers are not holding up hospital discharges for testing reports for anyone who's not suspected of COVID. Technically, it still applies, although we know that a lot of hospitals are testing prior to discharge, or at least on admission to the hospital. And we know that nursing homes must test on admission if it hasn't been done in 72 hours. Regarding voluntary moves with the family, right, thanks, Blake. This provision was intended to protect residents who chose to move in with family as a safeguard during the pandemic, and long-term care facilities must allow them to return if they have capacity and the resident meets the screening criteria. And of course, although you can't evict for non-payment, there's still the expectation that you have the right to get paid. And finally, as part of this section, long-term care facilities are encouraged to use telemedicine as much as possible. The second section of EL 148 covers protections for both residents and staff. And it starts with the provision that employees who have symptoms or who test positive must be isolated at home, and that employers may not discharge, discipline, or retaliate for doing so. And I think that this is detailed in an earlier, I think it's 36, but don't bet me on that, about employer and employee requirements during the COVID pandemic. Additionally, and this part is called out in the draft press release, are these bullets here on this slide that seems to be the focus for the AG's work. So facilities must cancel all communal dining and all internal and external group activities. When we looked at this thoroughly yesterday, we could find no Michigan guidance other than a complete ban on communal dining. We do know that CMS issued some softer rules in one of the FAQs included in QSO 2028, but there's no place in Michigan guidance that includes those flexibilities. So we're not sure what's going to happen here. It's our understanding that a lot of members have been doing different things so that residents don't have to eat in their rooms, and yet they're maintaining some safeguards. We're not aware of anyone getting cited for not completely canceling all communal dining, but we also know that surveyors have not been using Michigan guidance historically as part of their reviews. They've only been reviewing based on the routine CMS guidance. So we're not sure what's going to happen here. And actually, We would like to hear from you if you have any survey information about that when we get to the Q&A, the questions at the end of this section. Additionally, providers must ensure that they have, yes, go back, thank you. Providers must ensure that they have increased their disinfection plans using CDC guidance. They have to attempt to provide PPE and hand sanitizer. And that's been an issue a lot in some of the OSHA citations that illness and death have occurred in staff in some facilities because of a lack of PPE. We don't know of any such citations in Michigan, but we are aware of some in other states, especially Georgia. Additionally, facilities must inform employees of any COVID positives in the building within 12 hours. And they also have to let employees know of any CDC updates regarding COVID. They must keep accurate data about PPE and do the reporting along with all presumed cases being reported, along with any other data required by MDHHS. The last section of the executive order includes requirements for transfers and discharges. All facilities must report the presence of a COVID resident to the local health department within 24 hours. And unless an advance directive states otherwise, they must transfer any medically unstable persons to the hospital. Nursing homes, and this is specific for nursing homes rather than all types of long-term care facilities, they must make reasonable attempts to create a unit dedicated to care and isolation for COVID. If they have a unit, they have to be able to staff it, and they have to be able to provide enough PPE, or they're not allowed to have a unit and use it. And we know that the biggest barrier to those dedicated units is staffing at this point. All providers are required to adhere to the protocol for medically stable residents, which means that they have to place positive residents in a dedicated unit if they have one, or attempt to transfer to a regional hub alternate care facility, and we know that there aren't really any of those in operation, or a hospital swing bed. The reality is that there are few options here, really. And the order uses the word attempt. It doesn't say must. So as long as you have documented an attempt to move someone, we think that that would meet the provision. Hospitals must use the same protocol when they transfer COVID positive persons from the hospital first back to a regional hub if available, but they can send the patient back to the originating facility, alternate care facility, or available swing bed. Note that the bolded sentence here on the slide does not say nursing home, so it seems based on the individual circumstances. It is okay that these transfers move back to any setting that they came from, as long as it's considered a safe discharge. Hospitals are required to consider patient safety, not just during COVID, but all times. They are required to look at resident and family wishes, any local health department guidance. Otherwise, the hospital must keep them until a safe place can be found. One thing to consider here for long-term care providers is that the chances for transmission are very low after 6 days after onset of symptoms. So you must still be able to effectively isolate and care for the resident for 14 days, but after 6 days, the risk for actually transmitting is much lower. And so those discharges from the hospital might be a little bit less risky. And of course, providers must ensure that information about any advance directives accompany the resident during transfers. And although normal reporting requirements for transfers are waived right now, facilities must notify the resident and family if possible within 24 hours after the move. Laura is ordered to assure the proper level of care and services. That is stated directly in this executive order. Although we're not aware of any nursing home citations coming out of Michigan guidance. Excuse me. Any transfers that occur using these flexible approaches should be documented in your records as mandatory or emergent for safety reasons in order to have those flexible approaches be covered. In other words, for you not to be outside the guidelines. And of course, strict compliance with bed hole criteria has also been waived for right now. All these provisions apply to nursing homes, homes for the aged, adult foster care, and assisted living, except when specified for nursing homes. So, moving on, Blake. So, our thinking about the requirements for communal dining are up in the air. We do know that CMS flexibilities for nursing homes is pretty much countered by the Michigan executive order, and there is no other written guidance to change that. I have the FAQ question from the CMS guidance here. It kind of allows some social distancing with dining, but we don't have anything coming from the state that says that's allowable in Michigan. So we're going to pause now for questions and comments. We'd like to hear from members about any experience that they may have had with surveyors or consultants for HFAs and AFCs, and if they've encountered any difficulties concerning communal dining. Again, we do know that the draft AG press release calls this item out.
I do have a brief update on that press release. We did hear that it's actually going to be released Thursday morning. There was actually another delay, and that Dave and the board will be looking at that at today's board meeting to see how we should respond.
All right, thank you, Dalton and Deanna. Again, Leading Age Michigan would just like to thank our business partners who have stuck with us through our postponement of our annual conference. These are all the sponsors who are registered to just stick with us throughout that annual conference until we can get a new date set. We would just like to thank them again, and if you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. Right now, it looks like I only have one question, and it is, our residents dine in a large dining room with one resident at a table that is 8 feet apart. Can this continue?
That's what we're not sure about. According to CMS guidance, that would meet the criteria. However, since the executive order says cancel all communal dining, we're not sure what is going to happen. This was the first, well, I think evictions was actually first. This is one of the major things, though, that was focused from the draft AG press release. So we're not aware, and I don't know if surveyors are actually been in your buildings much. My understanding is that mostly they've done a lot of their infection control reviews from, I've actually heard the parking lot, but I guess we're just not clear. It was our thinking that the CMS requirement, at least for nursing homes, would apply. Assisted living, we always did know that there was no specific guidance to it, but we're not sure what it's going to do, but we're going to try and seek some guidance about that. But right now, it says cancel all communal dining.
Okay. Realizing that it's still subject to change, the draft of the AG's press release seems to indicate that the AG's office will be acting on complaints received by Laura rather than random on-site visits. Is that how you read it?
Yes, that's how I read the press release as well. When we heard about it on Friday, which was, I think, just a phone call, it implied that they were going to do some sort of on-site or review independently. But this press release did sound specific to any complaints. So you may not even hear from anyone about the AG's enforcement plans unless there are complaints coming from your facility.
All right. Someone says, just to give you some information, we have had 3 COVID surveys, the most recent one yesterday, and no new positives of residents or staff.
Great, great, that's wonderful. There's a large number of facilities, in fact, in Michigan that have never had any COVID. positive patients. So that's at least encouraging.
All right, it looks like that was the last question statement, so we can go ahead and move forward.
Okay, thanks, Blake. Okay, so on July 30, and this I think is probably related to the whole environment, the political environment and the actual COVID environment, that is kind of in alignment with the AG concerns as well. So Gordon put out what they call an epidemic order. He has several of them. He is the director of MDHHS. And they noted the uptick in cases that, has considerably been going up. And one of the issues is that while in the beginning of the pandemic, there were heavy clusters of cases, now there's wide community spread, and they're really worried about how difficult that is going to be to address. And they focus on 3 of the recent executive orders, one that requires the use of masks for everyone in public, limitations on gatherings, which got tighter in the last week or 2, and more detail around workplace safeguards for all areas except healthcare is not included there. They have their own set. So the order states that any violations of these orders by an entity regulated by a licensing entity will be referred to that licensing entity. So we're not sure whether or not there's the intention to start citing for these issues. We do know that in the past, Laura referred these issues to MDHHS, but we're not sure there was follow-up. So we're expecting this to change now, and the referrals might go to the Attorney General's office. According to this order, local health departments are also authorized to carry out and enforce, although we're not exactly sure how they would do that, other than perhaps to refer to the Attorney General's office as well. Law enforcement must investigate these issues, and they are allowed to actually stop access to businesses who fail to comply. And we think that that's mostly related to gyms and bars and things like that. And although the draft press release stated a fine of up to $500 as a possibility, this rule says fines up to $1,000. And any non-compliance with those executive orders are a misdemeanor. And there's always the possibility of jail up to 90 days for a misdemeanor in Michigan. A little bit better news. Yesterday, the governor put out a press release about coordinating with 5 other states in order to procure rapid antigen tests. And they're going to get assistance from the Rockefeller Foundation. So they're trying to purchase 500,000 tests per state. And a focus will be on use in nursing homes and schools. The 6 states will coordinate together on developing policies and protocols for the use of the test. If you want to read the actual letter of intent, it's at URL is at the bottom of the screen. So we're now going to move on to the CDC updates. This came out just this past Saturday, and it updates the guidance for using antibody testing. It's still not appropriate for detection of any current disease, but it is considered useful because it speaks to the degree of immunity that persons might have following infections. And it can help determine which communities who may have had high rates of infection who now may have a significant level of immunity, but it's still no place, there's no place for it in managing acute illness. Also on 8/1, the CDC issued guidance for pooled testing. And pooled testing has now been approved by the FDA, and we have talked about this briefly in some earlier webinars. Pooled testing is a form of diagnostic testing, and it's used, it's done by pooling a large number of samples together and testing them all at once. It can also be used for screening, which is what weekly nursing home testing is about, or for surveillance, which means trying to get a handle on understanding the prevalence of the disease in the overall community. So if the pool test is negative, then all tests are considered negative. And the reason why there's guidance here is because you have to make sure that you don't pool too many tests together so that you dilute a sample to the degree that it won't be identified as positive. If the pool is found to be positive, they'll go back and test each sample individually. So the CDC has created this algorithm that's based on the level of community transmission in order to identify how many positives they would expect to have, and that helps them determine how big the pool size should be. So this is the guidance for this. We've had no information that anyone in Michigan is going to try this, but one of the reasons why they like it is because it reduces the amount of resources you need to actually perform the tests on the laboratory side. The CDC has also updated its patient information. It has a lot of tools and posters and things like that for about COVID, and it's updated its patient information for older adults at high risk. So there are posters available, as you can see here, and the website address for some of this new consumer level education is at the bottom of the slide. So late last week, the CDC also updated its guidance on how to live in shared housing, such as unlicensed assisted living or independent living. And this is, these are suggestions, recommendations based for consumers. So this is not for healthcare providers per se. It contains information about how to safeguard yourself. And there are informational pieces about everyday preventive actions that everyone should take. And so this is a consumer-based piece that kind of tells them what to do in order to safeguard themselves. And there's good resident and consumer educational items here. At the same time, the CDC put out updated guidance for shared housing providers. And this guidance focuses on what to do when a COVID positive resident is suspected or confirmed in these independent kinds of settings. There is no requirement, of course, that residents notify administrators, but these entities are supposed to work with local health departments and to notify anyone in the building who might be exposed to someone who they know is positive when they do know it. Well, of course, they have to maintain confidentiality. Also, providers are expected to be providing information to anyone who you know to be ill and to the residents in general about how to care for themselves and seeking medical attention. So there is some consumer education recommendations coming out of the CDC for these independent living providers. And this is part of the same guidance. If a provider is aware of anyone who becomes infected, the recommendation is to encourage self-isolation and limit the use of any shared spaces, along with minimizing contact with staff. Precautions must be taken for any necessary visits that have to take place. Another recommendation that they had, which to be honest, we had not thought of, is to have a plan in case you might need to assist with any non-emergency transportation to a testing site or to non-urgent care. And the reason for this is because public vehicles, that the use of public vehicles for someone suspected of COVID should be avoided. And that guidance link, of course, is at the bottom of the slide. Last week, the CDC also updated its list of conditions that make someone high risk, regardless of age. So age is not an issue here at all. Most of these we did know. They updated this list and divided it from the conditions on the left side of the screen, which definitely will make you at high risk if you have any of those things. And oddly, type 2 diabetes are those that is a condition that makes you at high risk. Type 1 diabetes, along with the conditions on the right side of the screen, are thought to put you at a higher level of risk, but not as much as the ones on the left. And type 1 diabetes is there. So these are the conditions that a lot of our seniors have and put them at very high risk, but younger adults also with these conditions are also at high risk. The CDC has also issued its plans for working toward health equity. They put this out especially because of the obvious disparities in impact from the COVID virus. They're going to be looking in the near future about the availability of resources across these different groups with the goal to reduce the impact from COVID on certain high-risk groups such as African Americans and ESRD patients. And they will be reviewing whether increasing testing, increasing access to care will help with managing these disease and perhaps kind of level the playing field a bit for these persons who are at higher risk. Earlier this week, the CDC, obviously the CDC's been busy, they've issued a notice about a new service to clinicians who may want or need some guidance on how to treat a specific or COVID patients in general. So there's this group of volunteer infection control experts that can be accessed through the CDC who can help. Additionally, and how you can get help is in that first link there. There's also a CDC webinar coming up for clinicians on COVID and the impact in persons with diabetes, which is apparently a significant risk factor for severe disease. Earlier this week, and I thought this was kind of interesting, the OIG, the Office of the Inspector General for Health and Human Services, issued a report on the history of emergency responses over time, especially looking at H1N1 and responses during the Ebola crisis. And they've identified the characteristics in this report of healthcare facilities who were able to respond most effectively. The first area, and a lot of them are not really surprises, but I think that a facility could use this as a tool to think about their emergency preparedness plan and how they maintain that over time. So the first area involves building preparedness into daily routines and operations, using self-assessments, ensuring tests and drills over time, so that when you do a required drill or test, because your emergency preparedness plans, at least in nursing homes, require that, you make it a routine and not necessarily a special out of the ordinary kind of project. So also in this report, this HHS OIG report, there's a focus on preparedness and training and supporting staff. I think that over time, emergency preparedness kind of gets lost by the wayside because there are so many competing priorities. But facilities who continue to train and support staff over time in terms of emergency preparedness tend to do better during the emergency. And facilities who maintain communication and coordination within the community, especially with the coalitions for emergency responses, which are in each county, they tend to be better prepared. So the more you're engaged in the community, the more you're engaged with these coalitions and the emergency response officials, the better you tend to do in an emergency. And the last part is about planning. No, like you can move ahead. The last part is about planning, and that makes sense. But planning needs to be comprehensive, but also simple, practical, and it talks about, it'll talk about all of these bulleted areas in detail a little bit, about how to plan with local government, the importance of accessing electronic health records during the emergency, building in resource redundancies, making sure that all your bases are covered, etc. So this was kind of an important report, I thought, and could be helpful to someone who's really looking at their emergency preparedness plan. So at this point, I just want to let everyone know that the remainder of this webinar is devoted to issues that focus only on nursing homes, in case you might want to jump off. So we'll start with yesterday. Guidance came out from the department, MDHHS, issued a provider letter, and that letter identifies the reporting requirements for any facility that allowed Medicaid residents into non-Medicaid beds during the pandemic. There is a worksheet attached to the guidance. It's actually embedded at the end of the guidance, and it must be submitted to report each beneficiary that was in a non-Medicaid bed, and the begin dates and end dates for the alternative bed use, and the payer source if it's different from Medicaid. This worksheet, though, is not due until 30 days after the emergency expires, but I guess they're trying to think ahead here. So as a result, bed certification approvals will then be issued by the department. And in this guidance, they've also included the plan for returning non-available beds to that status if they were used during the pandemic. The department needs to be notified of the return of these beds in writing within 30 days after taking these beds again out of service. So I'm sure that you've all gotten this notice. There's a lot of details in it. I would certainly review it. The address for that notice is included here, and the email address that you need to send your notice in about non-available beds is listed as well. So our last topic for today is about a report from the Kaiser Family Foundation, which was just issued this week. It focuses on the COVID pandemic and the need for nursing home regulation. And nursing homes might want to review this report. It's rather interesting as well. They started with a review of the GAO report from May that discussed the widespread infection control deficiencies found in facilities over time. But also they noted that only a small number of nursing homes had been cited during the focused infection control surveys, and that a disproportionate number of deaths, though, occurred in residents and staff. So they're trying to put all that information together and make sense of it. Overall, about 40% of COVID deaths across the nation, that is, have occurred in residents and staff. So these next couple charts come from this report, and this one identifies the timing of many of the surveys, noting that as of July 10, most of the nursing homes had been surveyed. And as of June 1, only 13% had been cited with any deficiencies for infection control. So they consider that a rather small number compared to the numbers that we would have looked at prior to the pandemic in terms of infection control citations. So looking at this graphic, this is data from January 1 through March. And during that time, 48% had received an infection control related deficiency. So they're a little concerned about this discrepancy, but also they kind of put a positive view out there in a time when we don't get a lot of positive views. that, you can't really there's no data that says that the quality of the nursing homes has anything to do with the number of COVID cases that you might have. Community transmission seems to be at least more important of a driver than infection control procedures and policies. So last but not least, and I just thought I'd throw this in here for your information, the report included a timeline for the CMS guidances that have come out over the past several months, and we thought it might be helpful for your review, and so we've included it here as well. So that ends our presentation for today, so we will pause again for any final questions or comments.
All right, thank you, Deanna. I'm just going to get right into the questions here. We have a few of them. There seems to be no consistency in what they look at for the IC surveys. We had one in each building yesterday, and what they asked for, policies, etc., and looked at each location was very different.
Huh. Okay, well, we will definitely take that back to Laura and see what they have to say about that. Also, I have a question for this caller. Do they come into the building when they do these infection control surveys? Because we've heard that they're mostly been done remotely. So I will take the other questions, and hopefully that caller will comment.
She just said yes, they're coming inside.
Okay, all right, good.
One second, let me scroll up here. All right, I thought that pooled testing was not permitted. Are you saying that we can now do this kind of testing? It was not approved by FDA, I thought.
It has been approved by the FDA, but it has not been approved by the state of Michigan. But it might be an option coming down the road, especially with increasing testing and the burden on laboratories that has increased our turnaround time. So if it gets to the point where obviously the idea from almost every level is that it's only testing, obviously it's going to be safeguards as well and social distancing as well, but it's only testing that's going to tell us how well we're doing at any given time and whether or not it's going to be safe to open up the state. And so as those resources, testing increases, the resources for testing have been burdened. So this might be an option in the future, but at this point, Michigan's not doing pooled testing, but the FDA has approved it, and the CDC has now put out some guidance about it.
All right. Has anyone seen any guidance or decision tree for symptoms when determining if a staff member can work? This is becoming a big challenge. A staff member can show up and say they have a headache or perhaps just have some nausea, abdominal pain, and since these could be symptoms of COVID, they are off work for 10 days. In the beginning, there was some more clear guidance that they have a temp plus X symptoms. Now it just seems if they have any symptom, we have to take them off work.
I do think that, and I will look this up as part of the Q&A, but I do think that there has to be for symptoms that are not necessarily directly COVID related obvious symptoms, there should be some guidance within your facility from your clinical team, your medical director. The CDC always refers to what they call your employee occupational team. I don't know if facilities really have those often, but there does need to be some guidance from your medical director and your other clinical staff about whether or not this person is safe to work. If somebody comes in with nausea, it does not necessarily make sense that they have to be off for 10 days. So I think that has to be looked at a case-by-case basis, and you need to look at the actual symptoms. You know, one of the things is that cough. You know, cough is one of the symptoms. However, I cough off and on all the time because I have asthma. So just because I come in with a cough or just because someone comes in with a symptom does not mean that they are somebody who could be presumed positive COVID. So when the symptoms do not match what you think the predominant symptoms are, first of all, they shouldn't be working sick if they're really sick in another way anyway. But whether or not they have to be isolated and whether or not you have to send them home should be a case-by-case basis decided by your medical team, your medical director. There should be some parameters for that. And the CDC suggests that you look at that individually. And if necessary, you should consult with your local health department because they should have some resources to assist you as well.
All right. If we have a staff member with cold symptoms, is it your understanding that they need to have 2 negative COVID-19 tests prior to returning to work?
Someone who has cold symptoms. Well, someone who has cold symptoms is scary, but do they have cold symptoms with a fever? I mean, I think that a fever, chills, some other symptoms that would go along with that would be important to know here. Otherwise, they may simply have a cold. And again, I think that that's where you go back to your medical director and your clinical team, and you identify on a case-by-case basis whether this person, everyone's being tested every week. So whether or not they need 2 negative tests before they come back in is rather moot. But my feeling right now is if someone has an active cold, an active viral infection, they should not be in the facility anyway. But whether or not they have to be tested and whether or not they need to be isolated, that again would be a decision based on the case-by-case review by your medical team and your occupational health team.
What CDC article supports when to test an employee or resident again after being positive for COVID?
We did not get that from a CDC written guidance. I got that from the Department of Community Health, who, not Community Health, they're now called Health and Human Services, MDHHS, who contacted CDC. The department said that they would include that direction in their next frequently asked question document for reporting. I can send people, if you want, that email and that person's email address if that helps. But I don't have anything written from the CDC, from their website, that talks about reporting. I only have what the department told me, and that was this morning.
Okay. What is your interpretation of eye protecting? Are safety glasses appropriate at any time as opposed to whole face shields?
I understand that safety glasses would only be okay if they cover the entire surface of the face and protect the eyes completely. In other words, if there's any way that a secretion or air from a consumer breathing could get behind them, they would not be allowed. So it is, it doesn't say shield specifically in the CDC guidance. It says eye protection. So any eye protection that protects the entire surface of the eyes, along with a mask, of course, I would think would be acceptable. There is some CDC guidance that warns people about eye protection, such as regular glasses, that will not adequately protect. So as long as it seals the eye area off, my understanding is that it would be okay.
What information do you have regarding the vaccine and release?
I don't have any. I don't believe that it's coming soon. I hear the earliest we're going to see a vaccine is spring of 2021. The department is getting ready, though, as we talked about in our last webinar, and they want to make sure that providers are well aware of how to report vaccine usage, and they suggest that as we come up in the fall with influenza vaccinations, that these are reported in MICR, and so that providers who haven't been using MICR have an experience to use it, because the state's definitely going to want COVID vaccines reported when they are administered. But we don't believe that there's anything coming at least until spring of 2021, maybe earlier, but I mean, I hear the news reports just like everyone else does, so I'm not sure.
Our OCC Health is reviewing them to try to determine if there is some other reason for the symptom, but during an IC survey, the surveyor said if we don't know why they have nausea or a headache, they should be off work. We had the cold symptoms come up, and the surveyor said they need to be off work with those symptoms, even though they had weekly negative tests, because they could have COVID that isn't showing up on a test yet.
Oh, that's true. So I would be, I think the question really, they should not be in the facility, but I think the question really is whether or not you have to isolate them for 10 days or more. If they continue to have, and it would depend on the timing of the test. So if someone, you know, is tested 5 days after their symptoms and they're still negative, they should be back in the facility, I would think. But again, you know, that's your team. But anyone who's ill shouldn't be working. And if you do have symptoms that you can't attribute to something else, you should consider them as potentially COVID, as long as they're not very, very odd in terms of its relationship to the COVID symptoms.
So the eyewear essentially needs to be like a swim mask that makes contact with the face all the way around the eyes. This is what we are telling our staff is the only eyewear that's okay.
Yes, other than shields, obviously, yes.
Okay. It looks like that was the last question. So in case anybody has any questions right now, or if they think of something later, go ahead and look at the emails up on your screen right now. You can go ahead and shoot one off to the Safe and Calm email, or if you would like to reach Deanna, Dalton, or Laura Funch directly, you have their emails down there as well. We would also like to say thank you to Deanna and Dalton for all the information today, and we would also like to thank our members and participants. I believe we had around 85 members that took the time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder that we do have another Safe and Calm COVID-19 webinar coming up this Friday at 11 a.m. Eastern Standard Time, so you should receive a notification from that. Other than that, I hope everyone has a great remainder of their day. Dalton or Deanna, do you have anything else you would like to say?
No, just thank you for everything you do, and have a great afternoon.
Have a good afternoon, everyone.
All right. Thank you, everyone. Have a great day.